Dr. Gupta is the first physician to serve as the Director of National Drug Control Policy and lead the Office of the National Drug Control Policy, a component of the Executive Office of the President. This office coordinates the nation's $44 billion drug budget and federal policies, including prevention, harm reduction, treatment, recovery support, and supply reduction across 19 federal agencies, including the Department of Health and Human Services, Justice, Defense, and Education. In his role, Dr. Gupta serves as the senior most drug policy advisor to President Biden. Dr. Gupta has been practicing primary care for more than 25 years. I hope I got that number right. And has served in private practice and public health in towns as small as 1,800 residents and cities as large as 25 million. He opened his first medical practice in a small town in Alabama and has served as a local public health official and as the West Virginia Health, how he got from Alabama to West Virginia, I don't know, but as the West Virginia Health Commissioner under 2 governors, where he brought together public health, law enforcement, healthcare, faith-based leaders, and business partners to solve public health challenges in novel ways. He's a true public health professional. He understands the importance of partnerships and relationships and how much we can get done when we work together. In addition, his lifelong commitment to educating the next generation of physicians and policymakers has led him to serve as a clinical professor in the Department of Medicine at Georgetown University School of Medicine and as a visiting faculty at the Harvard University T.H. Chan School of Public Health. Through his works as a physician, researcher, a state and local leader, an educator, and a senior leader of a national nonprofit organization, he has dedicated his career to improving public health and public safety. And a little personal aside is I did have the opportunity several years ago to work with him on the National Association of City and County Officials Board. So with that, please join me in welcoming Dr. Gupta to Charlotte and to the Charlotte campus of Northeastern University.
Thank you.
So what we're going to do, number one, I want to take just a second to recognize who's in the room, because I think that helps with the conversation. So how many folks here are affiliated with Northeastern, either as students, faculty, staff? Raise your hands. Okay. How many in the room are public health, either state or local health department people? We've got some folks here, and I want to recognize a couple of folks from the state. Thank you for making the effort to be here. So how many are with healthcare service providers or systems? Quite a few. How many are here representing services to people with substance use disorders? How many are with other nonprofit organizations? Okay, business? Any business providers? Thank you. Great, a couple. So we've got a variety of folks, and I probably left some people out, and I apologize for that, but I think those are sort of the main categories that we were hoping for tonight, because it does give us a clear picture of the need to have relationships and lots of different partners if we're going to address this issue moving forward. So I have a list of questions. I'm going to try to get through some of them. I don't know whether I'll get through all. And then we're going to leave a little bit of time for question and answers at the end. Because of Dr. Gupta's schedule, we will make sure that we end right at 6 o'clock. And I forgot to tell y'all when you came in the door that those closer to the front of the room will get to ask the questions. Probably should have told you that ahead of time.
Still move, right?
Yeah, they can still move if they're so inclined. Okay, so you've been on the front lines of the opioid crisis for years, as it has evolved from heroin to prescription pain pills to fentanyl, and now this growing complexity of drug mixtures. Can you give us your sense of the current state of the crisis maybe think out loud about why the opioid epidemic has been so hard to tackle, particularly in places like rural North Carolina.
Well, thank you, Gibbie, and thank you for having us here. Really appreciate Northeastern's efforts on this issue as well. Something really serious is happening in the last decade or so, and we gotta recognize that, which is for hundreds of years, if not thousands of years, we were in what we call an equilibrium with plant-based drugs. We're talking about drugs like poppy, cocaine, marijuana, and others. Um, they required farmers and fertilizers. They had crops. They were transported and shipped in massive amounts. And you can certainly know where it's going and what you can do about it. Now, about 10 or so years ago, something dangerous began to happen, which is that Pandora's box was opened when you can start using a chemistry kit and creating with an internet almost the most dangerous compounds ever known to humankind. Since then, we've had several compounds that you can produce now just with the chemistry kit and internet in a one-bedroom apartment, which can kill, not just get people to suffer from addiction, but kill tens of thousands of people at one time. And that's the scourge. That's the change that has happened. And that's what you see in fentanyl, drugs like fentanyl, that are up to 100 times more potent than morphine. That Pandora's box isn't going back. We are in the phase of a transition because where the supply of drugs has become much more deadly, lethal, it's become complex because of polysubstance use, multiple drugs being used, and it's also become one where you could carry a small amount of these drugs and it could kill a lot of people. So we are in the midst of a transition, perhaps the most significant known to humankind, and one that will probably not be reversed anytime soon.
Thank you for that. So overdoses are a leading cause of death for Americans under the age of 40. Also a leading cause of death for pregnant women. Data indicates that COVID impacted the trajectory of the opioid crisis in North Carolina. Can you talk about how this aspect of addiction is harming the country and what specific strategies might help young people survive?
Certainly. And going back to it, that is a reason we began to see exponential rises in overdose deaths. So starting 2021, we began to see up to, not starting, but up to 2021, we were seeing up to 30% per year increases in overdose deaths. The drug supply was interrupted and disrupted. We were seeing a lot more different forms of things coming in, especially counterfeit or fake pills. So what's happening now, especially for young people, is because of this challenge of being alone, the loneliness, mental health challenges that people are feeling, especially post-COVID and during COVID, you would often feel like, okay, I need some help with my anxiety, or I need to stay up because of my exams. I'm going to go and online and order some, let's say, Adderall or Ritalin. The fact that has happened is that the internet has become so accessible and easy for young people to access and ship anything. But when they do, in this case, instead of asking for help, the likelihood of that pill will arrive in the mailbox, literally death will arrive in your mailbox, is 7 out of 10 of those types of pills have potentially lethal dose of fentanyl. And on top of that, when we looked at the data between 2019 and 2021, the adolescent overdose rates doubled. But people often talk about that. But what's important to look at that data is in 2/3 of those cases, there were bystanders nearby, but naloxone, the antidote, was not available. So it becomes more important that we have antidotes and countermeasures available when the drug supply has become so difficult, unpredictable, and it's coming in the form of fake or counterfeit pills, especially for young people. And this is the reason we have put on a campaign like Real Deal on Fentanyl, which is a social media campaign by young people, influencers for young people, that is telling them to do two things. First, know your drug supply is dangerous and get help legitimately through a private practitioner, whomever. Go ask your parents or a loved one. And second, carry naloxone, because you may not be someone, it may be someone that you know of in your family, your community, a random stranger that may be dying, and you could be that person that helps them live.
So you're suggesting that everyone carry naloxone?
Yeah, it's a reality we face today. Today, the fact is that of the 100,000 plus people dying, if we have naloxone available widely and extensively, we have access, we have affordability, and we have the ability to administer it on time. We will save tens of thousands of lives. It's because of that we have now made naloxone available over the counter. We've increased by hundreds of thousands and even millions of doses of naloxone that's being dispensed. We know that up to 500,000 lives have been saved because of that already, because of data we have. And we made it more affordable. Now it's available as low as $24 a pack, when it wasn't the case for many years. The whole idea is, I like to see naloxone available just like a defibrillator device or a fire extinguisher, whether it's private offices, malls, schools, restaurants, other public facilities, because that is the way we're going to be able to, while we work on other angles, we're going to be save people from dying. Because while we do need to get people the help and treatment and recovery, but you can't treat dead people. That's the problem. So we have to keep people alive as triage in order to get them the help they need.
You've spoken repeatedly about efforts to improve medical care and treatment for people facing addiction. Give us an update on where we are, especially in places like North Carolina. What efforts are in place to ensure that training is available for physicians and other healthcare providers to ensure they can recognize substance use disorders as a disease that requires treatment? Is it getting easier to find a doctor who can help when someone is facing opioid use disorder?
Gibbie, I think this is a very important part that you mentioned, that now we know that addiction is a disease that affects not only the brain, but the rest of the person and often their community and their family. So we have to recognize and catch up with the science. That's the first piece. But let me give you a story that has impacted me personally. When I started in that small town in Alabama, I had a patient, I'll say Billy, to cover the name. And the Billy was taking medications like pain medicines for a long, long time. He came to me, new patient. I was in rural Alabama, just in rural places all over across the country, including here in North Carolina. And I worked through his pain problem. We solved it. And then we solved it. He had no longer the pain medicines needs, but now he needed treatment for addiction because he was addicted to the pain medicine he was on. So I said, okay, well, I have the license to prescribe you pain medicine, but I don't have the license to prescribe you treatment for the pain addiction addiction. I don't have the ability to get that X license extra burden. So I sent him a referral to go somewhere 80 miles away. Several weeks later, I was on an ER call, and Billy came in and died in my arms from an overdose because Billy didn't go. He didn't have the ability to take time off from work, have gas money, and all of those reasons. As a result, I lost a patient. So it became important that we work to remove these artificial barriers that were created several years ago, like the extra license and everything. So one of the things we've done, and the president signed into law, is remove these extra barriers. Now we've gone from 129,000 providers that used to have this special license, like myself, which I eventually got, to almost 2 million providers. So every county right here in North Carolina now has a provider that can prescribe treatment for addiction. And that's an important piece. We need to continue to train folks to become comfortable, get rid of the stigma for prescribing. But the fact is today, over 46 million Americans suffer from addiction of some kind, 9 million from opioid addiction. If you're a doctor or provider and you think you don't have somebody in your practice, look again, because you're missing them. They're there. We've got to make sure that people are providers are screening for addiction, and then they are treating or referring appropriately. That's going to be a very important part. It takes time, but to get people the help, remove the stigma, and make it easy to get treatment than to get illicit drugs is a core element of what we're trying to do.
So to take that just a little bit further, I think what we see is a lot of the violence in the country can be related to substance use. And a lot of the people in our jails and prisons are suffering from substance use disorder. My daughter, my daughter is the DON, the Director of Nursing at the jail in Buncombe County. And I had a little conversation with her before we came down here. I said, give me a ballpark figure of the number of people you see in the jail. What percentage of those have at least one substance use issue? And I thought she'd say 60, maybe 65%. She said, oh, easily 85%. So how is the federal government, state and local, as far as you know, how are they addressing these substance use issues in our jails and prisons?
Thank you, Gibby. This is a really important part. When you have a crisis at the mass of an American dying every 5 minutes and you get to be put in charge of addressing it within, and you have to answer to the president, one of the things you have to do is take a public health approach, which means that you have to go where the data tells you. And what the data said to us when we looked at it, look, people who suffer from addiction end up at one of the three places eventually, either at a jail, a hospital emergency room, or at a place of worship. And then we have to go and start to reach those people there. When we look further at the data, we saw that obviously the first thing you can have to do is expand naloxone and treatment. At the same time, we found that up to 25,000 people were actually dying because of reentry. They were being released from jails and prisons, and the likelihood of overdosing within the first few weeks after that is 120-fold increase. So you're right. Your honor is exactly right. So we have 2 million people incarcerated every single day in this country. 90% will eventually be released, but up to 85% are related to drugs, and 65% have substance use disorder. So what do? We leave them in there, don't treat them, and they come out, they either die or they're incarcerated. So one of the things that the federal government is now working is with states like North Carolina to make sure that there are Medicaid waivers available where you can apply for and get the ability to pay through Medicaid for 90 days before release in jails and prisons. So that way the sheer burden of price or cost is taken off of the states in a major way. But then you have people who are actually getting the treatment, and then they have continuity of care when they're being handed off to community provider. And then at the same time, they're getting a job or they're going into something else or finding a purpose in life, and they're contributing to their local economy. So at one hand, we are spending money in incarceration, local taxpayer money oftentimes, but of this policy, we're actually going to be not only saving lives, but also saving taxpayer money and having contributions of tax. So this is kind of the approach that we're taking. And if we do this right, we have treatment universally available in jails and prisons, we expect to save another 17,000 lives per year. So we've done those predictive analysis, and these are big chunks of changes that we need to do through policy. But it's not only the right thing to do, it's also the smart thing to do.
Great, that's good to hear. So I'm sure that you're familiar with the North Carolina Opioid and Substance Use Action Plan. The plan has an increased focus on equity at its core, with an additional focus on lived experiences. We know that the stigma surrounding substance abuse in this country, especially in small rural communities, impacts the ability of accessing care, whether prevention, early intervention services, mental health services, and recovery services. How does the national effort address the stigma around substance use disorder that is still prevalent in our communities?
Gibby, one of the really nice things about the state of North Carolina has been its approach to abatement funds. And I think one of the most brilliant things that have been done here in the state, and obviously the Attorney General's office has led that, is how to get more of those dollars back into the communities and allow that to be used in a way to not supplant, but supplement the money that's coming from other sources, such as local government, state, and federal sources. It really allows that not only to provide those resources, fill in the gaps that can't be reimbursed through state, federal grants, but then also work on things like stigma, getting into communities and having a piece of that skin, part of that skin being playing into it. And it's long term. That's the other pieces that money doesn't go away. And we know in public health, we've got to have predictable sources of funding. And this helps have that predictable source where you can build programs around it, whether it's primary prevention in schools or it's getting like rides to treatment or allowing more expansion of telehealth and treatment for that. All of these things are important that has been done from a policy perspective from federal government, expanding telehealth, having methadone mobile vans available. But now this braiding of funding through the settlement funds allow those in between things that could often not be paid by other sources to be stitched in.
Yeah, I'm going to skip over a question. I'll come back to it. But that was one of the questions that I did have. I mean, this is legacy work. This is not to be taken lightly, and nor can we expect quick fixes to any of this. And wondering about the continued support for the infrastructure being built, both with the settlement dollars and with the federal dollars as well. I mean, in public health, we have a little bit of a history of look at 9/11, look at COVID. They throw a lot of dollars at us and then they go away. You build some infrastructure and then there's an expectation that those funds come from someplace later. So,
right. I think that's
anything else you want to say about that?
No, I think you're right, exactly. This infrastructure that can be built, especially states like North Carolina right now, because the model you set up, you become an example and a model for the country, for other states, how to do it right. We have obviously a state model law that talks about this, how to spend the money, but you're doing it, and it's really the right way to do it. The fact is right now we've from a federal standpoint have put in $167 billion already in this administration, 40% above prior, because the need is so great and those resources have to get to local communities. This is a problem that didn't happen overnight, won't be fixed overnight, but the resources are really important and critical and need to get into the communities in order to support those efforts that are happening, along with good data-driven policy.
Great. So again, dramatic increase in funding from the Biden-Harris administration. Are you seeing that the funds are going to the best strategies and programs? And do you think that there's really starting to help communities and people in addiction?
Well, absolutely. And I'm a kind of person that works with you have to look at what you want to achieve and work backwards in some way. So back in 2022, we put out the President's National Drug Control Strategy, in which we made a very clear prediction that here are the evidence-based strategy. If we put our funding and work together towards these policies, here's what will happen. The pandemic would start to level off in 2022. And then just like any epidemiological curve, it will start to decline in 2023 and onwards. So let's see what happened. And then, by the way, if we don't do that, we will start to see up to 160,000 deaths per year every year if we don't do that. But if we do, we'll save about 40,000 lives a year. So now what we have seen, after 30% rises per year prior to 2021, we saw a flattening of that curve in 2022. In 2023, we've seen a 5% decline, and our most recent data shows for 12 months, ending in March of 2024, compared to the year previous, there's a 7.5% decline. 7.5%. Now, again, we have a long way to go, but it seems, at least from a statistical and a data standpoint that the policy and the resources that are being invested into communities are taking an effect. That also means we must double and triple down our efforts with a sense of urgency because every life is at stake, and it's really important to know. Now we know what works, and we've got to double up, and that's why we have a number of incentives to try to do that.
So at least 79 local governments in North Carolina, many of them rural, have reported opioid settlement spending plans, with most reporting high-impact strategies in their plans. Are there specific efforts in rural areas that you believe are proving effective in addressing substance use? And are there other specific efforts that you think need to be implemented?
That's a great question as well. I think one of the first things we have to do is to ensure across population in rural areas, we make naloxone available. That's the immediate thing. It's important, but it keeps people alive. That's the first part. Secondly, we've made harm reduction, which means naloxone, drug checking, test strips, and citizen service programs, evidence-based, all with a great return on investment as part of the federal policy for the first time in the history of U.S. government. That means that there's funding available for that too, but some of the settlement funding can be, again, used to supplement those programs. That is also meeting people where they are and offering them help to move further along. And the third piece I would say is taking advantage of the telehealth opportunities. Like I talked about Billy. If telehealth was available, all Billy had to do was take 30 minutes off work right there and do a Zoom call and get his treatment. That did not happen. Billy's no more. So it's those opportunities in rural America that we can do now that were not available. That's been a silver lining of the pandemic, that we have telehealth opportunities now that are permanent that we need to do. And then mobile methadone vans and other opportunities. Those that I'd like to see more happen, I think we have that opportunity to expand treatment further. I also think we should focus on primary prevention, especially in schools. If that is not available, we should think about how to invest money into one of the best returns on investment that often doesn't get talked about, which is primary prevention, which again, evidence-based programs have historically yielded great returns on that as well. So because you have to invest in the next generation as well.
So local health departments across the state are speaking about this issue and trying to educate communities. But local health departments are part of the government. And in some of our rural communities, people don't want to listen to that part of government. So is there any particular effort? People will listen to physicians. So is there an effort to create a cadre of physicians who are spokespersons in those small rural communities that can sort of lead that charge and work with the local health departments? We can provide the resources to support them in that work, but to really be sort of the spokesperson around the destigmatization of substance use and some of the resources and services that need to be provided.
Absolutely. I think, one of the things we're doing within the various agencies, federal government, is we're trying to create a cascade of care for those who've sort of gone through the HIV pandemic. One of the ways we've been successful is making sure that there's universal screening, standards of care for treatment, and other aspects. So we're working with academic institutions and others to make sure that we think about how do we universally create standards to screen. So whether you are an orthopedics doctor or an eye doctor, you should be screening for substance use disorder, and then have the ability and confidence to refer it to the right people to begin treatment and support. I think this cascade of care work is critical in not only expanding treatment, removing stigma, including in healthcare, but actually getting people access and help. But I'll go one step further. As I mentioned, people end up at three places. And we've talked about healthcare, we've talked about jails. I think it's also important to reach out to faith-based communities because, look, that's a lot of people go there. And any information that could be misleading or prejudiced or not evidence-based could also mean the difference between life and death for those individuals. And there's a big belief in and trust in for people in their passion and what they're saying. So I think it's important for us to also think about how to, for local public health to engage their faith community as well to at least provide right appropriate information so that when people are reaching out, at least the right information and right resources are provided to them based on evidence.
So talk a little bit about the importance to support recovery. And while you're thinking about it, how can local businesses be a part of the solution?
I mean, that gets me excited every time because this is actually not all news is bad news in that sense. Here's why. There's well over 20 million Americans today in recovery. You wouldn't know it, but I will tell you, the people in recovery are some of the most hardworking, dedicated people that we know. And how do I know that? Because we have some people in recovery that are working in White House. Um, and they get the health insurance, they get the support, and they find a purpose. Um, the what's new, or maybe it's not new, is this um, for businesses to consider beyond providing insurance and employee assistance programs to become a business-friendly place of recovery is a game changer. I'll explain how. If someone in your business is, on the verge of relapsing and they're in recovery and they don't have the support, they don't feel like they have someone who will understand them, well, you might lose an employee, but you're also going to lose a person and a life from your business. And the recruitment is so much more expensive if you look at just dollars and cents than retention. So this is something that is not only the right thing to do, it's a smart thing to do, but it makes good business sense. But because it's been known that actually you save money by having a recovery-friendly workplace. So there are states like New Hampshire, which have 350 or so businesses that have become recovery friendly. You have places in like Hamilton County in Ohio, Cincinnati, that have over 50 places of business that have become recovery friendly. The county commission there has become recovery friendly. We're working right now in my office right now to become a recovery friendly because it's a procedure. We're happy to talk to you, whoever wants to how to approach that. But the point is, if we push more and more businesses right now. We have Google, we have iHeartMedia, major corporations that have decided to become recovery friendly workplace because they need the workforce. And they also have some of the most committed workers. And the whole idea is to have peers who they can call upon during their work that may not be in the line of command, the chain of command. They have someone to go to if they need that. And that's been a game changer.
So I noticed you didn't mention how many in North Carolina, so I'm assuming we've still got some work to do here.
I look, we're always optimistic. I'm sure there are that, if we have not identified yet, and I think there may be others we have. But the point is that what I like to see is a recovery-ready nation where states are taking this, local communities are taking this on, and businesses are taking this on. So we become a nation that embraces people in lifelong recovery, and we get the best workforce. And I'll give you an example why. Um, Not only are we losing about $1.5 trillion per in Joint Economic Commission report of Congress per year, 2020 US dollars because of opioid crisis. The GDP of Russia was 1.5 trillion in 2020. So we're losing the equivalent of that every single year. We're also the number one cause of death for working people aged 25 to 44 is the opioid crisis. Number one killer. And then we have the lowest fertility rate on the record in this country. If you combine these things together, we're not talking about 2, 4, 6 year election cycles. We're talking about a country that we need to shore up our workforce if we want to maintain our national security, public health, and economic prosperity. And that is why it's important to think about that way.
In the federal, state, and local plans, the ability to address social determinants, root causes, and key risk and protective factors is highlighted. You have an extensive background in addressing public health issues at all levels of government and healthcare. What do you believe is public health's most significant role in addressing these issues, especially in regard to opioid and substance use at the local level?
I think we definitely have to start working at those root causes. One of those is obviously the adverse childhood experiences. We know that, and this is a lot of conversation we have in law enforcement, believe it or not, is how to create programs that actually look after or understand the impact on young children when someone is getting arrested or is suffering from addiction. The same thing goes with folks who are pregnant and going through neonatal abstinence syndrome or getting into treatment. I think it's really important for us as a community, especially across rural communities, come together to understand the childhood trauma. We know in public health the impact of ACEs lifelong on all kinds of diseases. This is an important one. And I think it's important. We're talking about settlement funds, we're talking about other programs. I found in my time, both at local and state level, that some of the programs, like we had Birth to Three programs and others, had just the most important impact on the child. And it's not only public health in terms of ACEs, it's also about breastfeeding, the mother-baby dyad maintenance, and all of those. So I think it's important that we start to look at those structural determinants of health, and that also includes others like housing, lights, food security, transportation, broadband. Those things are also important and become part of this challenge of addressing the opioid crisis.
And again, considering the work that needs to be done on all of those issues in our communities and the workforce, with the needs that we're experiencing in the country and the workforce needs of public health, what do you consider the critical training, education, and experience that public health professionals need to be successful?
Look, if you only look at from public health, take a slice and only look at this behavioral health. HRSA has produced federal agency that we will drop off from a cliff in the next 5 years. There will be a need for about 12,500 mental health counselors, social workers, psychiatrists. And I'm not talking cumulative, I'm talking about 12,500 each extra need. So you expand that to larger public health, community health workers, peer recovery support workers. We're going to need a lot of that, a lot of people. So one way, obviously, we have to address the challenges, but on the other hand, we've got to think about outside the box, how to have programs that are providing traditional education, like right here. And that's one of the great things about, I think, Northeastern is having a campus that is developing the next generation of leaders right here in Charlotte and the Carolina area. But also, what are the non-traditional approaches? What are the other approaches that we could get people into workforce early enough? We were just, how do we start to influence high schoolers and others so that it does dual purpose? One, they're not getting into trouble. On the other hand, they're finding a purpose in life, which may actually allow them to be part of the solution.
So, the part that's always sort of challenging is there's so many different things that you need to work on in a community to impact all of these issues. The root causes, the social determinants, but also substance use, opioid crisis, and they all need to work together. That's one of the things that's always impressed me about your career is your ability to bring different groups together to work on issues. Can you talk a little bit about how you're doing that at the national level, where there's also politics being thrown into the mix? So how are you doing that?
One of the things is like to have fidelity to the problem and look for solutions to the problem rather than a set of ideology. That's the approach. And whatever that requires, then go after it. So one of the things we're trying to do is, like I said, is this many people are dying. The goal is to reduce that number significantly, and we're going to save tens of thousands of lives. How do we do that? Okay, if we need the business community to step up for recovery, we're going to work with business community. If we need naloxone to become available widely, we just brought for the second time naloxone manufacturers to the White House, and they promised to not only increase production of naloxone by 25%, but also significantly contribute to other efforts to expand the messaging. Um, Same way goes with faith community. It goes with academic community. It goes with making sure that there's appropriate training for individuals in public health and the medical field. Um, and it also is the same when we talk about supply side. I mean, I was in China in late June, and we talked with the Chinese about getting controls over, having substances scheduled, meaning turned into a way that it becomes illegal there to ship here or ship to Mexico. So it's a matter of really focus with the end and goal in mind, and then bringing partners together. I mean, this is a problem large enough that none of us, not individuals, not institutions, can alone solve it. But we all have a role to play at the same time. And that's why, not only is this part of the president's unity agenda, recognizing that, but also understand that this is apolitical. This is a problem that affects literally everyone across our communities. And we've got to work at it together.
So, and I mean, let's think about this a little bit deeper too, because at the local level, the funding comes down. The funding streams come down from your office. The funding streams come down from SAMHSA. The funding streams come down from HHS. This one is supposed to focus on ACEs. This one's supposed to focus on this. And they all have their own specific requirements that can be very extensive, which is a little challenging for community-based organizations, just saying. It's challenging enough for local health departments, but community-based organizations. But how, when do we get to a point where this funding can be sort of braided in a way that at the local level really allows us to do some of what you're talking about in terms of relationships and working together around addressing these bigger issues?
Great question. And for those of you who deal with this, you know exactly what you're saying, Gibby. Here's what we're doing. I'll give you start with the example and then go further into detail. We have at the White House a program called Drug-Free Communities Program. It's roughly around $100 million a year, and we cover about 67 million Americans with primary prevention across youth, 50 states. That includes multi-sectoral coalitions in communities to prevent youth substance use or delay youth substance use. And that is an evidence-based program with plenty of evidence behind it. But the way we approached it is we asked CDC, can we work with you so you can also use your other prevention funding in a way that aligns with this? And they were, yes, we can do that. So now we work with CDC to administer that funding across. That's just an example of why it's easy to say, well, we're going to run the funding piece, but it's much more effective when we can combine with other programs CDC. We're trying to do the same thing with whether they're programs of SAMHSA, another federal agency, and CDC. So we're working more and more to make sure that there's more partnership that's right before the braiding of those funds come in, so that we're going the same direction. Another example, we had a CDC program that was doing overdose to action grants. We got a lot of positive sort of encouragement from local communities that were receiving the grant, that we have all this grant to collect data on overdoses, but we're not getting the money to provide naloxone because then we have to depend on SAMHSA to bring that, and sometimes we're not getting that. So now CDC is also helping purchase naloxone. So it's these kind of things. It's a learning thing. And I think as us, we've been in local public health, we know that the real influence is by having those experiences and passing them on to our state partners and federal partners to see how much more. And that's exactly what try to bring to the table is the ability, because ultimately we've got to get more funding to the local communities and resources so that work can happen. But the more we cut the silos, the more effective that money becomes.
Yeah, we ask that you keep that up. That's great.
Yeah.
So my last formal question, how could this opioid crisis finally end? What gives you hope? And what do you think the timeline is for dramatically preventing and improving addiction and drug deaths?
Well, thank you. I really believe deeply that we can end this. The way we do it is we take a compassionate yet evidence-based approach that includes one of prevention, harm reduction, treatment, and recovery, while also on the flip side, taking smart approaches to supply reduction. So it's important. I'll give you an example on the supply reduction side because we haven't talked about this. You cannot open your television without hearing about the border and everything. When I joined the office, what I wanted to know from a public health perspective is how much of fentanyl is coming through the legal ports of entry versus the areas in between the ports of entry, which is the border. And the data I received was 90% of fentanyl comes through legal ports of entry. And there's 70 million passenger vehicles, around something like 30 million or 3 million or 5 million cargo trucks that come each year across our southern border. And that's how fentanyl is coming, and some people walking across. So then I asked, well, we have radiation detectors. Do we have drug scanners? The answer was yes. But you can't stop at that. I said, okay, if that's the case, how much of this traffic is being scanned by drug scanners? Can anybody guess what that number was? 5%. 5% across all administrations of the past. So this is not a political thing. So I said, and that's exactly, the president's approach was, why can't it be 100%? Not 20, not 50, why not 100%? So we began an approach now to start installing drug detection scanners at reports of entry to make sure that we can do that. So this is the example of like what gives me hope that there is evidence that we can actually exert on addressing the supply side in an evidence-based, data-driven way, while making sure that the problem at home is having the space to approach with compassion and getting people the help they need, and then getting those resources into local communities. Absolutely, there's hope, and absolutely, I think it's hard to put a timeline behind it, but I would say that if you look at what's happened in 2022, 2023, the data I've shown you, I don't know when was the last time we had a 7.5% reduction in overdose deaths, but I will tell you this is the time not to stop, but double down on things that are working. And this is why the White House Challenge to Save Overdose is so important. I would invite anyone to think about joining it. We're happy to provide you that information, but the whole idea is to get naloxone in your facility. I'd love to see naloxone right here, and make sure that people are trained in it.
Well, we will continue to watch your crystal ball and hope that everything continues to move in the right direction, which it is right now. So with that, we will open up to questions. Yeah, I see the folks in the back of the room. We'll get to you. Let's start here.
Hi, can you hear me? Thank you for coming. I was just wondering what your thoughts are on MOTA bill, modernization of opioid treatment.
So I'll try to avoid specific legislation because we try as a federal government not to opine on matters unless it goes through a process. But I will say generally, methadone which is one of the 3 FDA-approved medications for treatment, is a very important part of the treatment regimen. And for far too long, the access has been significantly limited to people. And that access that is there does not work for often rural communities, and it doesn't work for others often because their life then surrounds around having to get that every day. And we're working quite a bit within the agencies across federal government to look at all options to increase the availability of methadone to more people as a life-saving drug, a life-saving treatment. And we will be happy to entertain and look at any both legislation and other actions that could be to make sure that more lives can be saved and more treatment can be provided and access expanded.
Hello, thank you so much for your presentation. I've seen a New York Times article which calls you Biden's drug czar. I don't think this term was used, but I think it kind of implies that you have a lot of authority and power, and people are critical because you are not exercising the power the way they want. So I'm interested in your learning journey or learning curve. What has it been for you, and how have you navigated it?
So the terms don't matter to me. What matters is the work with a sense of urgency, because like I said, an American dies every 5 minutes around the clock. So 12 Americans would have died in the time that we're here. And that clock keeps ticking in my head all the time. So the office's job is, and it was created, back when President Biden was this Senate Judiciary Chair. It was interesting that my appointment through Senate goes through the Judiciary Committee. So it was very interesting as a physician in public health going through that. But the office, what it does is it does 2 main functions. First, it creates the president's national drug control strategy, the entirety, domestic and international, as well as supply and demand. And that's the first job. The second is it oversees the $44 billion budget across 19 agencies to implement that strategy. So whether it's Department of Justice or Defense or Health, various agencies, or education and others, that drug piece of the budget is what we do. So as you know, bureaucracy is large and in breadth and width. So what we try to do is as quickly put in efforts to save as many lives as possible. That's why you're sensing a sense of urgency in me to push to make sure that naloxone is available everywhere it can be. Right now, Major League Baseball has joined our challenge. Southwest and Delta Airlines are putting this in their kit. We have school districts across this country who have joined. I'll give you an example. LA school districts, just since they joined, they've used naloxone 50 times, 50 in their school district. Now, you can tell me all day long that this is not a problem in schools, but the evidence doesn't suggest that. And you don't have to have a child die in order to change your mind. Does not need to happen. And that's 50 seats in schools that are still filled because they decided to join the challenge. So that's the kind of work we do. And a lot of the work is effortful in a way that let's save lives as a triage mechanism. Let's expand treatment. Let's get people the help while we go smartly on the other side of supply side to go after not just the old law enforcement side, but also disrupting the commerce, recognizing that drug production trafficking is a commerce and disrupting that in terms of going after brokers, real estate agents, accountants, and all of those middle people, and denying the billions of dollars of money in order to be effective.
Go back there, and then I'll come to you. So thank you for both of the work you do. Dr. Gupta, thank you for your private and your public work. My husband's from West Virginia. And my son is in 7 years long-term recovery. We're from Virginia, but he found long-term recovery in North Carolina. So thank you, North Carolina. So, the question I wanted to ask was about, I'd love to hear what you said about access to naloxone, making this available. And everybody knows the people who recover from being dead is 0%. So recently, we were in Ohio visiting a customer there. We have a substance use disorder program in virtual reality. But when we were driving back from Ohio, we stopped at rest stops, state rest stops in Ohio. They have naloxone in the state rest stops. Is this something that can be done in federal facilities? I was so impressed. I took pictures and posted on Facebook to everybody I know. So I'm like, this is not boiling the ocean. This is making a cup of tea. Is this something that we could do at the federal level?
Thank you for your question, and I'm so sorry for your loss at the same time.
I don't have loss. He's 7 years in recovery.
Oh, my gosh, okay, my apologies.
No,
Apologies.
North Carolina helped him get
Got-
7 years clean.
God, my misunderstanding, sorry.
No.
I'm glad that he's in recovery. Let me answer. One of the things we do is at ONDCP, at our offices, we have naloxone on the wall. At HHS, Health and Human Services, there's naloxone on the wall. We are working to make sure that all of the federal cabinet secretaries look at this as having naloxone in their facilities. I also met with the Postmaster General recently and offered him to join the challenge, the White House challenge. And very quickly got a response that yes, they're going to join the challenge. They're going to look at all the 1,300 facilities for the employees to put naloxone in. So this work is moving, not fast enough perhaps, but it is moving quite fast. I'll tell you another thing. There's this United Nations meeting, Commission on Narcotic Drugs, every year in March in Vienna, Austria. So went there. We were meeting with our U.S. ambassador there, and she just happened to mention, yeah, we have naloxone. I asked, how come you have naloxone here in Vienna in your embassy? She said, well, we got a State Department cable and we followed it. So I thought, wow, that means that so many embassies across the world probably have naloxone. So this is really encouraging that your story, what you just mentioned, and when I look at that, I would love to see that picture as well and further share it with other folks. But it is really encouraging to see we were not here. Just 5 years ago, we were not here. People were talking about how enabling naloxone is, which is not true. But so the stigma is being removed in an hour-to-hour, day-to-day way. We can't often see it because we're in the fog of war. But we are, to everybody, all of you are making that progress and making it happen.
Hello, thank you both for taking the time to share with us and just to hear your passion. My name is Dr. Sharika Fair. I'm a psychologist, and I'm a former program director for SAMHSA, for Interdisciplinary Minority Fellowship Program that helps with train clinicians in terms of psychiatrists, psychologists, addiction counselors, mental health counselors. One of the prevalent challenge that most of them mentioned in doing that integrative work or interdisciplinary work was single pay services. So for instance, if a medical doctor was prescribing Suboxone for treatment, they were required to do a psychological assessment. So we would be brought in to do a psychological assessment. However, the payment could only be for one service. So are there any efforts to address that in terms of making sure that we're able to do that integrative medicine model?
Thank you. That's a really good question, and I think we didn't talk about the the reimbursement side of this model. One of the things is that we are very heavily dependent in this field on grants, and you don't treat cancer with grants, you don't treat diabetes with grants. heart disease. So one of the challenges in front of not just the federal government, but in front of the American people is how do we remove this from a stigmatized disease like cancer was 100 years in this country to one that has amount of research and development. Look, we have 3 FDA-approved medicines, but that's not enough. We need more R&D on this. But part of that's also developing reimbursement systems to match the times so it can become a part of the treatment infrastructure. We are working with CMS to the extent there's some development that has happened in terms positive development, but there's a long way to go as well. So thank you for your question on that.
Okay. Rahul, thank you for your time this afternoon. Your efforts and your work over the years has made me proud to be a public health professional with you. So I'm grateful for that opportunity and grateful for you being here this afternoon. I want everybody to thank him for being here.
Thank you. Thank you for having me. I was proud to serve with you on the Nature Board, and it is so good reconnecting with you, Gibbie. And thank you, everyone, and thank you to Northeastern for having us here.
Okay, okay. So we have another half hour for you to, what that was. Anyway, most folks can hear me without a microphone. So we have another half hour. I think there's still food and drink over here and an opportunity for y'all to get to know each other and to talk about how you might work together in the future. So again, thank you for being here. We're grateful for your time.